focusing on the efficacy and safety of the Holmium laser versus the bipolar in Enbloc population prostate. For my presentation, there's no conflict of interest, and I will go through the contents before giving a final conclusion. So as we all know, benign prostatic hyperplasia or BPH is a common condition affecting older men. It can cause urinary symptoms as well as the bladder obstruction. Over the years, we can see that the surgical treatment options for BPH have seen enormous advancement with a clear trend toward transurethral endoscopic intervention. Two of the more advanced and popular procedures are Holmium laser evaluation of the prostate, first devised by Gilling in 1998, and the bipolar triangulation of the prostate described in the early of the 2000s. For the advantage and disadvantage of each one, the HoLEP is no way safety, effectiveness, but it's come with a high initial cost and it needs a steep learning curve. On the other hand, the bipolar Bi TUEP is have a lower investment cost and can be easily to get used to, especially with the surgeon that is familiar with the conventional TURP. It is also suitable for centers that couldn't afford a modulator. So, according to the EAO guidelines, both HoLEP and Bi TUEP are first-line recommendation for BPH surgical treatment for the category of the prostate size over 80 milliliters, and they are good alternative for TURP in this category of 30 to 80 milliliters. So at Dương General Hospital, we have applied transurethral enucleation of the prostate since 2021, firstly by bipolar, and after the application of the HoLEP and modulator in 2023, we are mainly doing HoLEP now. But we also do some cases with bipolar and also with Holmium laser. So we do this study for achieve the objectives. First, we compare the efficacy and safety of both Holmium laser and bipolar in the treatment of the benign prostatic hyperplasia. And so second, we want to evaluate the effect of the prostate biopsy on the results of both procedures. So for our study was conducted at Department of Urology in Dương General Hospital with 63 patients with the prostate size over 40 milliliters. They are divided into two groups. The first one is the HoLEP group with 28 patients, and the second group is Bi TUEP group with 35 patients. We have some subgroups in which some patients have the prior prostate biopsy before the surgery, and some patients have not because of the not evaluated PSA. So for the technique we are using, we use the Enbloc technique for both, and the surgery was done by one surgeon for on case. So for our technique, it consists of 4 steps. The first one, we make the incision at the gap between the verumontanum and the lateral lobe so that we can expose the surgery plate. And the second one, we start to enucleation of the lateral lobe in clockwise and counterclockwise to be at the 12 o'clock position. The third step is we cutting the mucosal bridge at the 12 o'clock, the mucosal bridge connecting the adenoma and the membrane urethra as well as the bladder neck so that we can enter the bladder at the 12 o'clock position. And at the final step, we complete the enucleation phase and we push the adenoma into the bladder, and we use the cutting loop to chop the adenoma down in the Bi TUEP group and use the modulator in the Holmium laser group. So for the results, there's no significant difference between the two groups in terms of general and pre-operative parameters. The mean age is about 70, the average prostate size is about 80, and both groups have the IBFS, the QOL score, and the Quimax and the severe urinary symptoms. So for the intraoperative parameter, we see that both HoLEP and the Bi TUEP group have a comparable enucleation time, which is around 60 minutes. And there's also no difference between these two groups in terms of hemoglobin drops, catheterization time, and hospital stay time. the big gaps, and we can see at the adenoma management time, in which the HoLEP group with the modulator is totally faster than the BPH group using the cutting loop. They also similar with the some previous study saying that the HoLEP had a shorter operating time. But they also noted that the Bi TUEP also have a rational surgery time, so it can be a good alternative. So for the subgroup evaluation, we can see that there's no differences, no main differences between the biopsy and non-biopsy group. This is similar to the study done by Ali and Nafi, saying that the enucleation of the prostate is feasible, safe, and highly efficient in the patients that have the prostate biopsy 1, 3, and 6 weeks before the surgery. It is also noted that the cutting adenoma time in the Bi TUEP group, in which the patient have the prostate biopsy before, have a little bit longer time than the non-biopsy. It can be explained by the hemorrhage, and the surgical pain can make the manipulation of the cutting loop more difficult. And for the complication, both groups have low rates of complication, and most of the complication can be managed by preservable or can be used in medical intervention. It is noted that there's a rare complication that we have seen. It is a seminal vesicle injury. According to Ikonen and his colleagues, after the prostate biopsy, we can see on MRI the inflammation, adherence, and hemorrhage of the prostate capsule that makes the prostate capsule unclear. And seminal vesicle also have a hemorrhage and inflammation, make it look like the tumor. So in this case, we do the HoLEP in the patient with the prostate biopsy a week before the surgery, and we go a little bit too far into the downside of the bladder neck, and we injury the seminal vesicle. So for the evaluation at the 1 month follow-up after the surgery, both HoLEP and Bi TUEP groups show a great improvement in the urinary symptoms, as well as the quality of life, the big decrease in the prostate volume, and a big gain in the Qmax on uroflow. And there's no big differences between these two groups. So our results is similar to the RCT was done by many authors in the world. So the RCT was done by Izumi and Posa, and also Neil and their colleagues also say that both Holmium laser and bipolar enucleation of the prostate have achieved similar outcomes, and they are also efficient to treat BPH. So my conclusion, the triangular enucleation of prostate by both Holmium laser and bipolar is feasible, safe, and effective, and we've seen no significant difference between these two groups. And the triangular enucleation after 1 to 3 weeks is safe and effective. Thank you for your attention.